Assalamu alaikum everyone. Today we're doing a rapid fire review of diverticular disease, a favorite for UHS examiners. Let's start with a classic Viva question. What is a diverticulum? It's an outpouching of the gut wall, but remember, the acquired version we see in the sigmoid colon is a false diverticulum because it lacks the muscularis layer. Curious. Why is the rectum spared? Because it has a complete longitudinal muscle coat. Epidemiology check. In the West, it's a left-sided disease due to low-fiber diets. But in Southeast Asia, don't be surprised by right-sided diverticular disease. When a patient presents with persistent left iliac fossa pain and fever, think acute diverticulitis. Pathophysiology is key for MCQs. Herniation happens where the vasa recta penetrate the muscle wall. If that vessel erodes, you get painless, profuse rectal bleeding. Now let's talk about the Hinchey classification. You must memorize this. Grade 1, pericolic abscess. Grade 2, pelvic abscess. Grade 3, purulent peritonitis. Grade 4, fecal peritonitis. Mortality jumps from 3% in localized disease to over 33% once you hit grade 3 or IV. For acute cases, CECT is your gold standard. It shows wall thickening and fat stranding. Shouting exam warning. Never ever perform a colonoscopy or barium enema during the acute phase. Why? Because the risk of perforation is too high. You must wait at least 6 weeks after the inflammation settles to perform a colonoscopy. Our main goal then, to rule out colorectal carcinoma, which can mimic diverticular strictures. How do we treat it? Uncomplicated. Bowel rest and selective antibiotics. Abscess, grade 1-2. If it's over 3-5 cm, go for CT-guided percutaneous drainage. Peritonitis, grade 3-4. This is a surgical emergency. The safe bet in a septic patient is the Hartmann procedure. You resect the sigmoid, bring out an end colostomy, and sew up the rectal stump. We only consider primary anastomosis if the patient is young, fit, and the contamination is minimal. One last MCQ pearl. If your patient complains of pneumaturia or fecaluria, they have a colovesical fistula. The treatment? Resect the sigmoid and interpose an omental pedicle between the bowel and bladder. Pause. That's your 5-minute breakdown. Review the 20 MCQs I've provided to cement these concepts. I'm Professor Dr. Zahid Mahmood. Keep studying hard for those professionals. Allah Hafiz.